contrast, nephropathy, and the suits of James Bond. A 32-year-old gentleman presents with shortness of breath after going on a long airplane trip associated with pleurisy, hemoptysis, tachycardia, and hypoxia. He has stage 4 CKD from uncontrolled diabetes. Most of you will be worried about a PE, and some of you may be worried about contrast. In the next little bit, we're going to look at contrast, not only renal, but also sartorial, as well as associated paradigm shifts therein. In 2012, the American Journal of Kidney Disease published the Kidney Disease Improving Global Outcomes Statement on Acute Kidney Injury and Contrast Nephropathy. Prior to collaborating, the American College of Radiology early on didn't really have a diplomatic position. But when the consensus statement came out in 2020, I think they really came into their own, medically and holistically. The whole document has a clear, crisp sound and a new sheen of consummate professionalism that really gives the suggestions a big boost. It has been compared to manifestos, but I think the consensus statement has a far less bitter, cynical sense of humor. Similarly to how the consensus statement is a response to a previous entry, the suits of James Bond owe their origin to the one and only Cary Grant, who was originally approached for the role, but of course turned it down. We'll be looking at the contrast between each Bond and his suits. There are 6 questions the consensus statement answers, much like the number of James Bonds listed here. What's the difference between contrast associated and contrast induced AKI? I'm not going to read all of these because it's right on the screen. So as we answer these questions, we'll have to look up, look down, and look out for the sources used, like any good historian. And before proceeding, a special thanks to both Peter Brooker and Matt Spazer and their book From Tailors with Love, without which none of this would be possible. AKI, defined as a 1.5 to 1.9 times increase in the baseline creatinine, an increase of 0.3 milligrams per deciliter, or a urine output over 6 hours less than 0.5 milliliters per kilogram per hour, occurring within 48 hours of intravenous contrast media administration, had been termed contrast-induced nephropathy. But like a lot of things, definition was changed, the reason being that a lot of people in the hospital who require contrast for things tend to be pretty sick with a lot of comorbidities that predispose to AKI, what we call confounding. Secondly, the studies on which all these suppositions were based were, for all intents and purposes, never controlled. And this leads to the next point. Can you have controlled trials when the intervention in question is thought to be harmful? And the answer is no. You can't ask pregnant women to smoke to see if smoking has an effect on the unborn child because it's ethically and morally bad. So the definition was changed. Unless it could be absolutely proven AKI was due to contrast and absolutely nothing else, one would use the term contrast-associated nephropathy instead of contrast-induced nephropathy. Talking about contrast, we'll see a notable contrast between Cary Grant's suits and Connery's, starting with the shoulders. Grant's are rigid, defined, and padded, whereas Connery's here in this navy blue lounge suit from Russia with Love is the movie. They have less padding and they have more of a draping rather than a shaping quality. Here we can see the contrast, and it's much more pronounced. Grant here still in North by Northwest, Connery still in From Russia with Love, though obviously not in the navy blue lounge suit, though still with the grenadine tie, I believe. The cut of Connery's suit is called a conduit cut by the tailor Anthony Sinclair, as characterized by a less severe drop, or the difference between the chest and the waist measurement, which gives his Bond a more draped than shaped look throughout the films. Here in the last frame, we see M's more formal attire with thicker lapels, and of course, a bow tie, indicating a more formal attire compared to Bond's tie. Though we will see Bond mix formal wears between movies, but that is not for today. To recap, because of confounding and ethical limitations on study design, by and large, the term contrast-induced nephropathy has been supplanted by contrast-associated nephropathy. Confounding. So, confounding. There's a lot of confounding factors with both contrast administration and AKI, as well as George Lazenby's here on Her Majesty's Secret Service, which is a top-tier Bond film in this style. Historically, a lot of buzz surrounding contrast has been related to coronary angiography because it has some notable differences from other contrast modalities. Number one, the injection is intraarterial and suprarenal. Two, the contrast medium dose to the kidneys is more abrupt and concentrated because of that. And three, you cannot have control groups for coronary angiography where you don't use contrast for obvious reasons. Most investigations of contrast-induced AKI have not included control groups for what were thought to be bioethical reasons that we just talked about. So the question became, how can you show significance if randomized controlled trials are thought to be dangerous? And the answer is propensity score matching, a statistical method of making conclusions from observational data. Obviously, a randomized controlled trial is the best, but we've already been over a zillion times why you can't do that. So here's, in a nutshell, how propensity score matching works. You take a control group with various characteristics, age, weight, sex, height. You have a second group with some exposure with similar matched characteristics, the age, weight, sex, whatever. You plot these elements on a grid and match each group element with the nearest element in the other group, and then you find an average difference between these things. And it will tell you the likelihood, 0 to 1, that they would have been assigned a treatment. Ideally, you would want things with high propensity scores because it essentially tells you who got what, and then you, based on who got what, you can make conclusions on depending on what outcomes you saw. So members of the American College of Radiology took over 10 years and 1 million CT scans and 250,000 patients to narrow down 157,000 scans stratified by presumed predisposing factors: diabetes, heart failure, acute renal failure, CKD, nephropathies, to see the effect. Surprisingly, it showed a decrease in the incidence of AKI in the non-contrast group, SONCON. When a further analysis was done on people who had undergone SON and contrasted scans, there was no significant difference in AKI outcome. A few other trials had used similar statistical analysis to evaluate for other risk factors, with GFR seeming to have some sort of sway. But how much? Well, we'll talk about these risk factors in a bit, but let's talk about other risk factors, mainly Bond's style in On Her Majesty's Secret Service, where Connery had narrow lapels, Lazenby had medium ones. I mean, it looks fine. Where Connery's waist was hardly taken in, Lazenby's was suppressed. More shaped than draped, and more in vogue, you can say, than classic. Some results were good. I think this looks fantastic. Some were bad. I don't think this is a good look. You have the appearance of striped suits, again, giving shape through the lines. And, of course, Playboy magazine's only Bond cameo. So, to recap, when a more rigorous statistical analysis was applied, with a much larger base, they were talking about 1 million scans, no statistically significant relationship was found between contrast administration and AKI. So what's the risk? Well, here you go. Here's what the consensus statement says. So what's the deal? We just came off a study saying how there's no relationship between contrast and acute kidney injury. why the warning about contrast depending on GFR? Well, the reason is more than one study was done. At the time of this guidelines publication, there were 4 major studies on the subject, all randomized, all with well over 10,000 patients, and all propensity score adjusted and matched, but with slightly different results, leading to some interesting recommendations. When looking at these studies in people with a GFR greater than 45, iodinated contrast is not an independent nephrotoxic risk factor. In those with a GFR 30 to 44, IV iodinated contrast is either not nephrotoxic or just rarely so. Similarly, if using creatinine, one of 1.6 or greater seemed to be an independent risk factor for AKI after contrast. You can kind of see here. But, then again, look at all these other independent risk factors right here. Coronary artery disease, diabetes, diuretic use, you're in the ICU, recent transfusions, recent surgery, vital signs. And here we look at it crossing the neutral threshold of 1 right here. You don't see that if it's under 30. But take a look right here. Take a look at the number of people in this subject. 4,472 compared to 7,000. When looking at the above studies, 2 showed that IV iodinated contrast material is an independent nephrotoxic risk factor in patients with stage 4 and stage 5 CKD. And the other 2 were unable to find enough evidence to make that claim. Worth pointing out is that in the 2 studies where elevated baseline creatinine or low GFR is associated with AKI after contrast, there seems to be a pretty significant decrease in the amount of subjects in that population by at least a factor of 10 when compared to normal subjects. Right here, 44 versus 538 versus 7,000. And this is causing some pretty big whiskers in the confidence intervals. The high risk in bond suits, though, comes with Roger Moore. A high risk, high reward tenure for my money. Now, my grandmother says that he's the most handsome Bond, but that's, again, not for today. Here he is with his navy suit under a Chesterfield coat in Live and Let Die. I think it looks fantastic, and the whole thing is just great. But like the theme of our journal, there is still contrast in Moore's sartorial choices as Bond when comparing to Connery and also to Lazenby. In the coat, the lapels are now very wide, much in keeping with the times. And his pants, as seen in the gun barrel sequence, have a flare that does date them smack dab in the 1970s. We also see this later on as he checks into his hotel. Wide lapels, wide ties, and at least 4-inch collars here. Very groovy, no doubt. So a slide summary, a creatinine of 1.6 and above, or a GFR of 30 or below. There may be an effective contrast, or there might not be. But the joint recommendation is leaning more towards there may be. But don't forget the order of magnitude difference in the fewer number of subjects, as well as significant independent risk factors that we had seen before: diabetes, surgery, transfusions. The 1980s. So perestroika and glasnost out east, and in the Wild West, an aggressively heavy foreign policy focusing on lavish outspending, feeding the image we have of big Wall Street execs in their power suits. Unfortunately for Timothy Dalton's James Bond, the flagrant overspending was spent on Iranian missiles and helping the Mujahideen instead of Bond's wardrobe. The power suit, a staple of 1980s fashion, has large padded shoulders and a full cut. It's big. To emphasize the presence of the chest, power suits had a low button stance, low button right here. You can't even see the button, it's so low right here. And it has a low gorge, which is this little nick right here in the lapels, which the lapels also tended to be wider. Again, a 2-button approach was the most common, but a 3-button jacket was also in style. Roger Moore famously had one in Interview to a Kill. The former was often open and undone. Look at that. Definitely more drape than shape. So we just spent some time looking at suit heaviness, now to look at contrast heaviness. The reason why the osmolality question came into existence was related to the proposed mechanisms for contrast and kidney damage. I say mechanisms as a plural because there are many theories, none more particularly potent than the other. We have a direct nephrotoxic effect in the tubules theory, the famed reactive oxygen-free radicals, toxins that destroy the body and the brain, caused by eating too much red meat and white bread, per Rowan Atkinson in his Never Say Never Again cameo, as well as medullary ischemia. The diagram here kind of shows the crux of it. A high osmolarity allowed good opacification of small structures, but there was concern that the high osmolarity drew increased fluid and sodium into the renal vasculature, requiring more energy and oxygen to get the channels working, which may not have always been possible. Additionally, reactive vasoconstriction was thought to occur in response to the vasodilation, leading to oxidative stress and the release of these oxidative species. There's also the thought that both the osmolality and osmolarity cause an osmotic diuresis, which can dehydrate and cause AKI. Personally, I love this explanation because looking at urine labs is a baller move. So worth noting here, low and high osmolality terms may be misleading because both contrasts are supraosmolar. The data collected for the article mentioned here is a result of an analysis of 25 randomized controlled trials comparing isoosmolar and low osmolar contrast, both intra-arterial and IV. This slide is more for any radiologists, but there is no meaningful difference between low and isoosmolar contrast, it seems, with respect to AKI. So as a cool little slide recap, low versus isoosmolar contrast makes no difference. So by the end of the 1980s, the Bond franchise required some prophylaxis, both sartorial and directorial, against its demise. The 5 John Glenn films, from Octopussy to License to Kill, placed him in the bottom tier of Bond directors. And by 1995, when GoldenEye, by Martin Campbell, came out, the Italian house Brioni had its shot at the franchise and would not stop hitting home runs. Just look at this. Look at this. Look at this. Look at this. Now, those who know that these stills are from different films, but all are Brosnan's Brioni. The cuts are less extreme. The lapels are less wide. The gorge is higher. I would call it a dramatic elegance. Prophylaxis, you can say, against the years of stagnation. Speaking of prophylaxis, is there any benefit to prophylaxis prior to contrast? Like all great answers, it depends. The consensus statement tells us that over a GFR of 30, prophylaxis is not indicated, and that it is reasonable in people with AKI and GFR under 30, barring under obvious contraindications like dialysis or CHF. Preventative actions prefer isotonic mediums like normal saline as prophylaxis, both prior to and after contrast administration. The biggest concern is related to dehydration, as in the dehydrated state, renal blood flow and GFR are decreased, and if there is any effect of contrast, that it may very well be accentuated. The studies tend to favor normal saline over half normal saline and saline straight without any sort of diuretic chaser. Worth noting, the clinical journal CJASN, Clinical Journal of the American Society of Nephrology, also isn't too jazzed about bicarbonate and IV N-acetylcysteine. Bicarbonate had been used in the past, but meta-analysis failed to show any advantage similar to IV NAC, which is no better than placebo. So to recap, prophylaxis is indicated with a GFR under 30, assuming no dialysis or CHF. Who gets screened? Why, and why does it matter? Because of the previously mentioned risks associated with a GFR under 30, people with a GFR under 30 should be screened. Additionally, a neat study in Singapore asked over 1,300 people a set of questions known as the CHOIC questionnaire. Any history of proteinuria, history of hypertension, blah, 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 those kinds of questions, and found that people who had been told they had kidney issues were overwhelmingly likely to have a GFR under threshold, as well as those with a known history of diabetes seem to fall under the GFR of 30 category. Is this generalizable? Not really. Is it useful? Yes. But in an inpatient setting, more than likely you will already have a BMP unless someone is coming in and they need beyond stat contrasted imaging. And if you really think about it, people on whom you do not have a BMP and you are really, really, really strongly considering giving them arterial contrast, do you even care about screening and doing the IV fluids before and after, which, as we saw earlier, may or may not be helpful? Going back to the original question, if you think someone has a massive PE, do you really care if their GFR is 28 or 14 or 4? Are you going to give them fluids and strain their already strained heart? If someone comes in with a STEMI, are you going to load them up with fluids in the setting of fulminant heart failure? In the PE, will you not get a CTA? And in the STEMI, will you not get a cath? You know, so when do we hold back on contrast? Well, we need to ask Daniel Craig in his very polarizing role as James Bond on when to hold back. He certainly started off strong with his Brioni suit, pictured here, you know, lean chest, jetted pockets, suppressed waist, peaked lapels, a notable difference, of course, and a high gorge with padded shoulders. Certainly shaped, but what a shape, you know, once again, dramatic elegance. Tom Ford takes over in Craig's next film, the much maligned Quantum of Solace, which, like the tailoring, is certainly not without its flair. For what it's worth, I do like the movie Quantum of Solace. I think it's unfairly ranked much, much lower than it should be. Here we have the straight shoulders replaced by pagoda shoulders with a nice swivel up. The breast pocket is also now curved. The lapels roll up a little higher and are now thinner and more fashion forward. But as we continue this trend, we'll see disaster. Lapels itsy bitsy, collars barely spread, a bunch of extra garments here, the waist way too suppressed, sleeves much too short, the fit way too tight. Not a fan of the clip tie, but whatever. Women's glasses, cuffed pants, that's okay, I guess. Shoes with lifts, and you end up looking like some nouveau riche 14-year-old Italian. So he certainly should have held back. So where do we hold back? Where do we hold back on, whoa, what the hell is this? Where do we hold back on contrast? Well, if we previously discussed, you know, like we did, if it's do or die, do it. Otherwise, if their GFR is 30 or less, consider giving them saline. All right. Well, how about people with these low GFRs? Do you give them dialysis? Absolutely not. What about those on dialysis who can still pee? Well, essentially just treat them like stages 4 and 5. Consider giving them some saline, I guess. If they can take it, though, be careful. How about if you have one kidney? Well, it doesn't really matter. Use the same cutoffs, though consider caution with a GFR under 30, maybe under 45, depends on who you ask. And of course, should you hold nephrotoxic meds, always hold nephrotoxic meds. So here's the recap. With the balance between the radiologist's yin and the nephrologist's yang. So 1 and 2, it's probably not contrast induced. More than likely you mean contrast associated. Number 3, it goes without saying, trust the kidney folks with stage and kidney disease. 4, contrast probably won't mess up your patient's kidneys. At GFR under 30, including those with AKI, pump the brakes a bit, but don't pump the handbrake. Number 6, personal history of kidney disease is the strongest risk factor for AKI after contrast, but again, remember all the other confounding factors. Number 7, talk to your consultants, holy moly. 8, if you're worried and they can take it, maybe give them some saline. So how do you tailor imaging choice and associated risks? Much like how the approach to each patient is customized to his individual lab measurements and medical personality rather than a pre-existing model, the best cut or the best suit is cut from a pattern derived from a client's exact measurements rather than a pre-existing one. In both cases, the best choice and the best approach is bespoke.